Hi, everybody. Welcome back to another episode of Hybrid Healing Hour. Today, we are going to be talking with a cosmetic breast surgeon, Dr. Stephen Schuster. Thank you for coming on.
Oh, thank you for having me. Brian, Deanna, it's a pleasure to be here.
Great. And I am so excited about this because I feel like breast surgery is something that is done a lot, but maybe not talked about as much. However, I've heard a few questions more recently, and I would love to just dive in and have a wonderful FAQ session with you.
And in primary care, we do a lot of clearance for breast surgery.
I know, and we appreciate it.
But that's the only part of it we see. We see, what they're going in for, but then patients ask us questions and like, they don't have the answer to that.
Well, hopefully you also see them afterwards, and certainly our goal as plastic surgeons is not only to do the surgery, but to really educate the patient. And that's really the most important part of my job. So let's dive in, see what we can discuss.
So Dr. Schuster, will you please tell our audience a little bit about yourself and how you got to where you are today?
Okay. Well, I'm originally from New Jersey. And most of my training was in the New York, New Jersey area. But then when I finished all my training, my wife said, well, it's too cold up here, so I'm moving to Florida. Are you coming? And that's how I ended up in Florida. But I did my general surgery training and med school at New Jersey Med in Newark, New Jersey. Then went over and did my plastic surgery residency at Albert Einstein and Montefiore hospitals in the Bronx, and trained in a wide variety of plastic surgery procedures. Came down here, opened up my practice, and was very fortunate that I had a lot of patients, and many physicians referred to me, which was a very nice, to me, that was the greatest compliment. And the best compliment for any plastic surgeon is when a fellow physician refers a family member. To me, that's the ultimate compliment. Mm-hmm. So I still do a wide variety of reconstruction. I still do all of the cosmetic procedures, and we do them usually in our office. Our office uses board-certified anesthesiologists, which gives patients a lot of comfort knowing that. And I'm also on the faculty at the University of Miami. I was invited to join there as a voluntary faculty, so it's not a paid position. I do it because I still believe in paying it forward.
I love that.
Yeah.
And so how long have you been a plastic surgeon?
I've been in practice over 30 years now.
Wow. I'd say you probably have some great experience.
I really do. And one of the nicest things, I have some patients that I took care of 25 years ago, and I'm now taking care of their children. So
I love that. That's one of the reasons why I chose primary care as well, because I love that whole, dynamic and getting to keep in touch with your patients.
Yeah, it's really, it is nice.
Now I want to know, what about, what are your, top 3 things you do in your practice?
The 3 major procedures, the 3 procedures I'm known for are rhinoplasties or nose jobs, breast, and that includes not only primary breast augmentation, but very often redo breast augmentation. If you've ever seen the show Botched, all of those procedures that they're showing, I have taken care of. So, unfortunately, but
right.
I have seen those.
But that's why we need people like you.
and I do a lot of facelifts. So those are my big 3 procedures.
Great. But your office does more.
Oh, we do everything. We do all types of body contouring as well. My partner and I, Dr. Kovacs, will do mommy makeovers. We'll do liposuctions, thigh lifts. Tummy tucks.
Awesome.
We do all of those, including hair transplants.
Wow. Yep. Great. Well, today we're going to be talking about breast surgery, so let's dive right in.
Sounds good.
All right. So let's talk, I guess, directly more about breast implants for a little bit. So what are breast implants and what are the different types available to these days?
Well, basically, there are two types of breast implants, saline and silicone. Now, silicone was developed back in the early 70s, and it has evolved a great deal. It used to be that those implants had liquid silicone in them, and that's what caused the problem. It ended up that silicone implants were taken off the market in 1992 and weren't allowed routinely back on the market until about 2004. And then what happened was the silicone was no longer a liquid silicone, but was a silicone gel. So you could essentially cut an implant in half, squeeze the gel out of the implant, and it will go back into the implant. Made for a much better implant, a much safer implant. Now, during that intervening period, really only saline was available. And saline was a good substitute. Notice I didn't say great. Mm-hmm. It was a good substitute. It had some advantages in that if that implant ruptured, you would go flat within 24 hours. So you'd know it. It was sterile saline, just like we do if you get an IV. But it also was a little heavier. It rippled a little bit more. So there were some problems associated with it. But it still is considered a good, viable implant. And about 5% of my patients opt to have saline for whatever the reason may be.
Okay. So going into the process of choosing which implant is the right one for that patient, I mean, I'm assuming the person wants to know, okay, what's going to be more realistic or what's more, I guess you could say, not bouncy.
Feels more natural.
Right. Or not natural, like if they want more perky or.
Well, that's part of the consultation. And the consultation is not just coming in and speaking to a salesperson, which you may hear about at a lot of these walk-in clinics in south of where we are. Let's put it that way. A consultation should include sitting down with the plastic surgeon, discussing what your desires are. You may say to me, I want to be as big as possible. And that's fine, but that's not the majority of my patients. And I like to say my goal is to give patients a size and shape they're happy with. I want to give them a breast that has normal erotic sensation. And I want to give them a soft breast because no one likes to hug rocks.
Right.
So if I can achieve those goals, I've done a really good job. And really that's what I'm trying to do. But more important than that, the consultation should include what the risks are. Well, doc, what do I have to worry about? I mean, are these good for life? Well, no, they're not. These silicone gel implants usually last around 15 years, and then the recommendation is to exchange them. Now, my practice is a little unusual in that we've just recently added implant surveillance, and it is not a mammogram, it's not an ultrasound, but it's a way to look at the implant with an ultrasound to see maybe there's something that you think is wrong. At least take a look at the implant. And any of my patients, we do that in when they come in. Usually if they think they're having a problem, or let's say they're 5 years down the road and say, do I need to change my implants? Then you go into the exam room. And the exam involves doing a breast exam, making sure there's no lesions present. Find out, of course, what the family history is. If you have a patient whose mother and grandmother each had breast cancer when they were 40, you're going to want to get a mammogram on that patient 10 years before the earliest diagnosed stage. So I'm going to take certain measurements, and we use three-dimensional cameras. So you come in, I take a three-dimensional picture, it gets downloaded, and then we sit there and look. And what do you like? Do you like this style? Is this what you're looking for? And although it's not 100% perfect, it gives me a real good idea of what a patient's trying to achieve.
Sure.
Because trying to describe it is sometimes very difficult.
I'm sure, yeah. Wow.
You talked about breast cancer risk or taking a history. If someone had the BRCA gene, would that preclude them from having breast implants, or would it still be?
It would not preclude them, but I'd want a more thorough exam. I probably would want an MRI scan just to evaluate any lesions, if there are any present. So I think you'd go, in my opinion, I would go a little more into depth to see what we need to do to make sure this is safe for you. Okay. Now, and all of my breast patients, augmentations, lifts with implants, they're seen every year. There's never a charge for a follow-up visit. They're seen every year, just as a matter of surveillance. Hello, has everything. So I enjoy doing that. It keeps me in touch with my patients.
I like that follow-up. And so I do want to touch on talking about surveillance. So what are some of the complications of having breast implants that you might see?
There are several. Of course, like in any surgery, bleeding and infection can occur. Fortunately, this really isn't wood, but I'll knock on it anyhow. We want to minimize that, of course. Sensory changes. On a breast augmentation, about 90% of women have normal erotic sensation. 10% will have decreased sensation.
Is that over the entire breast or like just the areola and nipple area?
The nipple areola.
Okay.
Okay. Implant rupture. Of course, we're always concerned about that, so that's why we follow patients. And most importantly, or most commonly, the concern I have is something called a capsular contracture, or a capsule. And it's the body's natural response to a foreign body is to wall it off, to minimize its existence. So we try and avoid this by using, all sorts of techniques to minimize risk of infection and minimize handling of the implants. So those are the things that I'm concerned about. And the good thing is with the implant manufacturers now, if you have a significant capsule, usually they will replace the implants at no charge. So that's a savings of $1,800 to a patient.
Wow.
So it certainly is significant.
Now, does on a capsular contracture, because I have seen that on some of my patients, and that's, I would say, one of the examples of having like rock hard breasts.
Exactly.
Okay. So like they stay right where they are and they're very solid feeling because of that wall around the implant. Now, is the implant itself hard or is it the wall that we are feeling?
It's the scar tissue around the implant.
Okay.
When the body tries to wall something off, the smallest surface area to volume ratio is a sphere. Mm-hmm. So the body will try and literally wall that into a sphere as best it can. So, and because it can't move. Mm-hmm. Now, one of the little tricks we do is I have my patients do what are called pocket expansion exercises. It's a fancy term for massage.
Okay.
Okay. So they're moving the implants to try and keep them nice and soft. And I encourage them, you think they're getting a little hard? Come in. Let me see you immediately.
Okay.
So
you recommend maybe like massaging the breast tissue immediately, once you clear them post-op, right?
We show them how to do this massage. There's certain techniques we use.
Okay, great.
So when you remove the implant, the scar tissue is still there. Is there ways of getting rid of it?
We remove the scar tissue. If they have a bad capsule, I'll take out the entire capsule, okay, and then put a new implant in.
Okay. And now you talked about how saline is ripply. I've actually seen, sometimes women are stretched out a little more depending on the size they want to be. And I could actually see a ripple and feel the implant through the skin on some people. Not necessarily your patient.
Well, even if it is my patient, I mean, patients have different wants and desires.
Right.
If a patient says, I want to be as big as possible, my goal is to say, look, this is what you're going to have to put up with And if you want that, fine. But there's a line in my consent that says I am requesting implants larger than what Dr. Schuster recommends.
Right. Yeah.
So, patients have to realize, and for the most part, most of my patients are not looking
for
like that.
Right. Yeah. So that is less likely, I guess, with the silicone implant, would you say?
Well, rippling with silicone is less because the silicone gel stays throughout the implant. Mm-hmm. With the saline, it doesn't have a cohesiveness, so it kind of falls to the bottom of the implant.
Gotcha. And now, can you get capsular contracture with the silicone?
Oh,
or
absolutely.
Any implant? Okay.
Any implant.
It's just your body's scar tissue forming.
Right.
Okay. Very good. And now we've heard a lot about people getting implants removed lately. Why would that be?
Well, there has been a lot of talk about two things. One is called BII, breast implant illness. Now, certain women say they have all these vague complaints that they attribute to breast implants. Unfortunately, we have no way of diagnosing this. There's, I guess, 8 million blood tests you can do, but none of them will tell you have BII. And some women will have their implants removed, and they say immediately they feel better. Now, whether this is a psychological effect, I'm not smart enough to give you the answer. I don't know. What I do know is, unfortunately, there have been plastic surgeons who have been promoting this thing called en-bloc resection, which is really a dramatic procedure to take out the entire capsule and the implant without having any leakage. And the problem is there's no indication for that. And it is rather disfiguring. So the only time I recommend doing that is if a patient has this other problem called ALCL, anaplastic large cell lymphoma. It has occurred in 300 cases presumed worldwide.
It's not very,
not very common.
So it's very, very rare.
Yeah.
And in that case, it would be indicated. But otherwise, I would just tell a patient, if you want the implants removed, we'll remove a portion of it, of the capsule, and the implant. Maybe do a lift if you want, or let's say wait a few months before doing a lift. So those are the options I would give them.
So I kind of want to, that kind of alludes, yes, if they don't want an implant again and they want to remove it, I'm assuming they've probably had some stretched out breast tissue and they probably will look a little flat and deflated.
Exactly.
Is there any way to do an improvement to the breast tissue without implants, like a breast lift? Like, even I think of like the mommy makeover, right? Like when mothers have children, they breastfeed and then boom, everything starts dropping and deflating. And so what is there an option?
Well, certainly a breast lift is a possibility.
Okay.
Now, some patients, depending upon how much the skin is stretched, if somebody comes in who's had these enormous implants, they're 5 to 105 pounds, and they have 600 cc implants, their skin is going to be stretched. Mm-hmm. And you take out those implants, sometimes if you just let it sit for a few months, that skin is going to shrink. It's going to regain some of its elasticity, and you may need to do less of a lift.
Oh, okay.
The other thing is you can also do fat injections. So it is not the same as an implant, but maybe you can get, if you're an A, maybe you can get somebody up to a B with fat injections. So certainly those are the options that are available.
Now, if that person works out regularly, because I will say, as a female, I personally see, and I hear many other females say this, the first thing that I notice weight loss in might be breast tissue. And then that's also one of the, it could be one of the first things you see a gain in too. But can you lose those fat injections?
Yeah, absolutely.
Okay.
Remember, these come from other areas of the body. If you are, let's say if you have a little abdominal paunch and you get liposuction, I take out 800 cc's of fat, and now you're really flat on your abdomen. You say, why not put it in my breast? I really don't want implants. Well, now you have this new body. You are really happy the way it looks. You go out and buy all these new workout clothes, and you go work out, and you lose that fat from your breast.
Right.
So certainly that can happen.
Okay. And does the fat ever move? Like,
No.
I mean, okay.
Because
I didn't know if it could look,
That's a real misconception.
Okay.
The fat is not injected as a clump.
Okay.
In fact, it's injected in very fine threads of tissue.
Okay.
Because you want that fat to get a blood supply from the surrounding normal tissue. So by doing that, there's blood supply all around it. So that's why you don't have to worry about it moving.
Wonderful.
You mentioned breast lift. Can you explain what the procedure is for a breast lift?
Sure. When we do a breast lift, it's basically moving the breast tissue to a new height. Now, just like in breast reduction, unless it's a very, very unusual case of a breast reduction, the nipple is not removed, and everybody thinks, it's taken off and put on the back, and then you put it back on. Well, on both of these cases, you're basically moving tissue around. You're moving the nipple to a new height, tightening internally breast tissue, and that's how you get the lift. Now, there's 3 different types of lifts I do. The first one, if you have just a little bit of drooping, maybe just an incision around the areola, the dark area around the nipple. If you have a little bit more than that, maybe it'll be more like a lollipop, which is around the nipple and straight down. But in very severe cases, and patients who have a lot of skin and a good amount of breast tissue, you may have to extend that with a modified anchor scar that is one of the techniques of breast reduction as well. But it's done the same way. You just don't put an implant in.
Very interesting. Now, what are some, reasons why people might want a breast reduction?
Well, first of all, let's say you're 16 or 17. And it's not uncommon for 16 or 17-year-old girls to develop very rapidly to a large size. They may be a size 4 from the breast down, and they're a double D. And it's very difficult when you're in high school to be a double D, although it sounds very nice. But walking into a bathing suit store, you can't go in and buy just a regular bikini. You have to now go to the, quote, older patients or older women's section where you get separates, button-down shirts, suits. All these things psychologically are imposing, along with the discomfort from bra strap grooving, finding a bra that's comfortable. In the summer, especially in Florida, intertrigo, irritations under the breast.
Yeah.
We see that a lot with the rash underneath. That's itchy and red and sweaty.
I've seen a case in which I was involved with as an expert, where this was a 20-year-old, and the surgeon had taken off 7 pounds from each breast. Now, she already had neurologic symptoms. She had numbness in her hands. She had severe scoliosis from this. And, so that's the extreme example.
Wow. And I'm assuming, with that, we see posture, like the weight that people don't realize that the breast can put on your chest and pull you forward and arch your back and your shoulders when we should have better posture and sit upright. And the amount of back pain, or then you get your neck is messed up.
Some girls do that just to hide the breast.
Right.
Yeah, no, you're absolutely right. It's I will very often kid my patients, and I'm very lucky that I have just a wonderful group of patients. If they're in the building, they'll stop in to say hello to the girls in the office.
Yeah.
So I always kid them. I say, you just have to be careful. Remember, we took out 3 pounds of breast tissue from each breast. So you may feel a little off balance. I don't want you falling backwards because you're used to doing that to stand up straight.
That's funny.
So I've never had a patient not laugh when I've said that to
Right.
them.
So can you go ahead and tell us a little bit about like what a patient should expect in terms to surgical scars on either breast augmentation with implants versus reduction?
Sure. Well, breast augmentation, the technique really has not changed a lot in years. There's been variations. For a while, there were some crazy ones, but I would say most of my patients, I opt for an incision underneath the breast. It's usually about 4 centimeters long, let's say 2 inches. You can go do the entire procedure that way. The reason I like that technique is it has the lowest incidence of sensory change as
Is that
opposed
because
to...
there's less nerves there?
Well, also because you're not interrupting the nerves that are along the areola.
Okay.
So that's the technique that I prefer. I've also done many through the areola, a very rare occasion through the armpit incision. I don't like that for several reasons, and the main reason has to do with the lymphatics. So, when we get a patient who we're doing a mastectomy on, we'll do what's called a sentinel node. And the sentinel node depends on those lymphatics. So if you interrupt those, you may have to go in and really do a major resection as opposed to just taking out one little node. So that's not my preferred technique. People have done them using endoscopes. There were even some people who were doing them through the belly button with saline implants, which I could never understand. But
Yeah. Doesn't sound
anything to
ideal.
make a gimmick is probably worth trying. Now, so that scar is usually a fine line.
Okay.
With breast reduction, it's very rare that I use that anchor scar anymore. The technique I use is more of a lollipop scar. But that scar is a scar that goes around the nipple and straight down, just like on a lift. And you can do everything through that. So that's the nice part. Also, I combine that with liposuction along the sides because a lot of women have fullness. And what do they complain about? Well, I have this fat that hangs over my bra. I hate that. Can we get rid of that? So at the same time, I'll do liposuction there, which will minimize it a great deal. It also means they drop down a bra size, so they may go from a 38 to a 36.
Right. Which I think, like women obviously know this, but men don't. A lot of men out there don't understand that the bra size, the number is the circumference around the chest.
Correct.
Yeah, and so if somebody has a wide base chest or a fatty chest, like their number is going to be higher. That's not the cup size.
Right. And in actuality, a 34C breast is the same breast volume as a 36B. So, it's all proportional.
Yep. Interesting.
So another breast surgery that we see is inverted nipples. Can you talk about inverted nipples?
Sure.
What are they? And
Inverted nipples are just contractions of the milk ducts. And it can be embarrassing for women, but the treatment for it is usually releasing the milk ducts, a very small incision at the base of the nipple, go in and release them and pull the nipple out, hold it with a little stent for a few days. The problem is you may lose the ability to breastfeed. So I don't advise it for women who are considering having children.
okay.
Now,
And often you may see it after having children, it occurs.
right. Now, if somebody has breast implants, can they still breastfeed?
Absolutely. Remember, the implant, at least the majority of my implants, are partially under the muscle. So you're really not approaching the breast tissue at all. And that's why I like going under with the incision underneath the breast, because you avoid as much of the breast tissue as possible, which minimizes risk of very low-grade infection, which also limits risk of capsules.
Right.
So, but even if I were to put an implant over the muscle, which I might do in somebody who's a professional tennis player, golfer, now pickleball player, you're not going into the breast tissue. So there's no reason why they can't at least try breastfeeding.
So is anyone using shaped implants anymore?
Shaped implants have really come out of disfavor, mostly because of this problem, ALCL, anaplastic large cell lymphoma. The greatest number of cases were associated with Allergan-shaped textured implants. And in fact, Allergan they didn't actually have a recall, but they offered any patient who had these implants, they would give them new implants at no charge. They wouldn't pay for the surgery, but they would at least give them the implants, which again was $1,800, $2,000. So that was at least a significant offering by their standards.
Okay. And so one of the questions, I think, even as a provider, I'm a little torn at times, is mammogram screening after somebody has implants. So a lot of women out there are afraid of rupturing the implant from mammogram because of the compression. So what is your opinion on that? I want to know, how do we screen patients for breast cancer essentially after having implants?
Sure. My feeling is the risk of a ruptured or the risk of having a rupture from getting a mammogram is far less than the risk of missing a breast cancer in its very early stages because you didn't get a mammogram. And most of the mammogram centers now are very much aware of it. It's the compression seems to be less. There's a lot of the digital mammography. They're very willing to do ultrasounds, and if anything, an MRI. If there's a lesion that's even you can't see very well, they'll get an MRI.
Mm-hmm. But it is still recommended that we do mammograms.
Absolutely. In fact, I recommend anybody with a family history, and regardless of whether what their BRCA status is, 10 years before the earliest diagnosed case in the family, getting a mammogram. So if somebody is sick, had a breast cancer at age 60, or let's say a postmenopausal breast cancer, and you're coming in at 30 for a breast augmentation, I wouldn't insist on it. I'd recommend it. But certainly if somebody in the family had it at 41 and you're coming in at 30, I would tell you, let's get a mammogram just to play safe.
Right. Okay.
And would you recommend doing a mammogram and an ultrasound?
I leave that up to the radiologist. If they think there's something they can't see, then by all means.
Okay. Now, I have had where we've done a mammogram or an MRI, breast imaging, and then I do see that it says there is leakage, right, of breast implant leakage. But otherwise it was normal. Well, this person actually still also has capsular contracture, but she doesn't want to do anything about it. She says, nope, I'm not in any pain. I'm not having any problems. I just want to leave them alone. Now, is it bad if they have leakage? Like, do we have to insist on them seeing somebody to have that taken care of, or can they stay that way?
There are many women who don't even know they have ruptured implants. Okay. I just took care of a woman. Actually, she had her breast implants the same day my wife and I were married.
Oh.
Which was June 15th, 1974. And she never had them changed. And
you said earlier they last about 15 years? Okay.
Well, she had capsular contracture. So, of course, I said to her, you're 79, obviously you want me to take these out. Do you want to lift? No, I want new implants. She said, I don't have any plans on checking out yet.
Okay. You know, that's
Actually, what she said is, I don't think there's an expiration date stamped on my back.
good for her. That's awesome.
great.
Well, this has been a blast. Thank you so much for coming on. I think you've answered all of our questions, and I would look forward to having you on to talk about other plastic surgeries.
That would be my pleasure. It's really been a wonderful time here. Thank you.
Yes. And can you tell our audience how they can reach out to you or find
Sure.
you?
They can call the office, and we still offer complimentary cosmetic surgery consultations.
Okay.
My office number is 561-912-9191. They can go to our website. That's Dr. Schuster at schusterplasticsurgery.com. They can email me directly at Dr. Schuster at schusterplasticsurgery.com. I should say the website is www.schusterplasticsurgery.com.
And you're also on social media, Facebook and Instagram, which
Yes.
I will post all of this in the show notes.
Sounds great.
And the name of your office?
Stephen Schuster, MD-PA, or Schuster Plastic Surgery.
Perfect.
Either one. And the nice thing with our office is, if you desire surgery, we have a fully staffed OR recovery room. You can even stay overnight if you have a big surgery, which is really a nice advantage for many patients.
Very nice.
Yeah. Thank you. It's
Thank
been
you.
great.
No, thank you for having me.